I love to learn and I love to teach. So I'm super excited to be here with you all. And I really appreciate you taking the time to learn a little bit more about visceral manipulation. Really, my goal here is to increase your curiosity and awareness. We'll be covering a little bit of history, some pain referral patterns. We'll go through anatomy review, do some case studies, talk about some research, and then treatment concepts at the end. And the goal here is to understand a little bit more about visceral manipulation and how it affects the musculoskeletal system. And then how do you recognize a patient that might need this work? So trying to give you that overview. What is visceral manipulation? It is a manual therapy, so it's a hands-on approach that's very gentle. It's encouraging the normal tissue slide and glide and mobility because movement is life. And with the idea that any of this fascia that surrounds the viscera is connected to the whole system. So how these areas might be influencing. We like to say how the contents are influencing the container. And for organs and viscera structures, right, organs, to properly slide and glide, they need to be able to move without any restrictions in relationship to their neighbors. So for example, we take up to 24,000 breaths a day, and our diaphragm moves with each breath. And the kidneys are just below the diaphragm, and they move with each breath. And they move up to 1 inch and sometimes more if you're running with each breath, which means in a day they can move nearly a half a mile. So it starts to give you some perspective of how much all of this is moving and how much it needs to be able to move properly for our whole system to function properly. And so I want to show this video. The liver on the left, how much it moves, that's a shallow breath, and how much it moves with a deep breath. And so think of just on the other side of the liver is the diaphragm, and it acts like a snowplow, right? You guys are getting into snowy season. It pushes all the visceral contents with each breath. So it helps keep that mobility. So it starts to give you that perspective of how much this tissue needs to move. So I'll be talking about visceral manipulation in relationship to the Barral Institute because that's the main area where I've been trained. I've also taken some coursework from others, but the main area that I use. But I wanted to kind of give you a little background if some of you might have training in other visceral manipulation or have heard of it. So there is Hara massage, which is a Japanese-based, Chine-san, which is a Chinese-based visceral abdominal massage, the Arvigo technique, which is based out of South America. Again, that's a practitioner and teaching the client how to work on themselves. Then there's the Wern technique, also known as clear passage, which is based out of Florida. And that was developed by Belinda and Larry Wern. And they do extensive visceral work, but they took, right on their website, they talk about how they took their training from the French osteopaths. So some of the foundation of what they do is off of the Barral work. And their work is very different than the Barral work, and we'll dive into that. But from what I've read, I haven't had a session with them, but they do a 5-day program that's like super intense, long hours, and can be quite expensive. But they have some research on their website that starts to support their work. So just to kind of give you a little bit of idea about them, because they have practitioners all over the country. And then the work that I've been trained in, which is the Barral Institute. And so I'll be going into that next. And so that was developed by Jean-Pierre Barral. He is a French osteopath who started out as a PT. And he developed visceral manipulation and then went on to co-develop neural, vascular, manual, articular manipulation. So these are very specific coursework that gear towards anatomy specificity. So wherever there's a restriction in the body, they have techniques for those areas. And so a little more about Jean-Pierre is he's 78 years old. He started teaching this work in the US in 1985. He's been developing it since the late 70s, early 80s. He did a clinical rotation and worked in a lung hospital in France and realized that he had the opportunity to do the dissections after people had passed. And he started seeing patterns of where they had restrictions in their lungs and they had, same side neck and shoulder complaints. And he was curious. And so he started really looking at this work more and more, doing a lot of cadaver dissections and studying, and then slowly developed this work over the last 40 years. And so he still teaches internationally, he still practices, and he lives in France. And so this is, again, the training that I've had is through this institute, but there are other approaches out there. There's even, I forgot to mention, the Institute of Physical Art has their visceral manipulation. John Barnes has some, Herman and Wallace has some under their umbrella. And even I think Ramona Horton does some. So there's many other avenues that do some work. I can't speak to their work as much because I haven't done their training. So I'll be talking about this work specifically in relationship to visceral manipulation, but the principles apply pretty globally. So why do the viscera need to move and slide and glide? Because they might have adhesions. How do adhesions happen? They can happen from anything from infections, and I'll be going on to that in a moment. But I wanted you to see this image because you can see the fluidity of the tissue, and this is an adhesion between the lungs and the rib cage, and how that with every breath, if this adhesion's here, it could change how that lung can move. It could change a fulcrum. It could change how you posture. And so starting to get an idea of this image and some of the other images that you'll see here that have this quality are from the Barral Institute cadaver dissection. And they have a fresh frozen cadaver that they dissect over several days. So it has a different quality because it hasn't been embalmed. So what might cause visceral restrictions? And why might they lose their mobility? Because they become inflamed and dehydrated, and then the tissue can't slide and glide. And again, this could be from things like birth trauma. So either the C-section from the mom, or, if it's an older client, they might have had forceps. More recently, now they're using suction. Motor vehicle accidents and whiplash. And I'll get to an anatomy slide and I'll talk about that a little bit more there. Infections, right? Pneumonia, UTIs, COVID, all of these things can create inflammation in the system and start to create restrictions. Surgeries, of course, we understand tissue has to heal, right? Think of a total knee scar. What about those scars that happen on the inside when somebody's had a C-section or an appendectomy or a cholecystectomy? All of those things start to influence how that tissue can slide and glide. Sports traumas, collisional forces, concussions, falls onto the coccyx can affect the whole system. Food allergies and intolerances are on the rise, right? We're hearing so much about celiac disease and gluten intolerance and allergy and to corn and soy and dairy and all of these things create some inflammation in the gut. And the gut is where we have our immune system, right? There's 70% of our gut is where the gut associated lymph tissue is. So we start to look at how gut inflammation can affect the whole system and our health of our whole person, inflammation, etc. And then medications, for example, acetaminophen is hepatotoxic for some people. So that can then affect the liver. So if the viscera have a restriction or have a problem, how does the brain perceive pain? How does this system communicate? And so there's not very many pain receptors in the viscera themselves, right? You can eat an entire bowl of or a gallon of ice cream and you feel bloated and distended, but sometimes it's hard to tell where the pain is. And so it's hard to always pinpoint that pain. And that pain is communicated through the autonomic nervous system, through the parasympathetic and sympathetic nervous system. So if you remember those two systems, we have the sympathetic nervous system communicating through the sympathetic ganglion, which is just anterior to the thoracic spine mostly. And then again, our vagal system, right? So the right and left vagus nerve communicating. Sympathetic is our gas pedal. Parasympathetic are our braking system, right? They're neither good nor bad. They both need to be in regulation and balance for our whole system to function well. And so our organs communicate to our brain through the system. Our vagus nerve is 20% efferent and 80% afferent, right? So it's gathering information more than telling the gut what to do. And the gut has its own nervous system called the enteric nervous system. And so what might visceral pain present like? True visceral situations where you're concerned, either you need to refer back, and we'll talk about the red flags in a moment, or you're like, this is really sounding like an underlying visceral issue, not just musculoskeletal pain. I put these in so that you have a little bit more tools in your toolbox so that your spidey senses have a little more information. All right, so visceral pain tends to be non-specific. I underlined the key things, non-specific. It's not like, oh, I fell and hurt my shoulder and now my shoulder hurts. It's like, I don't know, my shoulders started hurting and I don't even remember when it started. It's not activity dependent, right? So it's like, oh, sometimes it hurts when I reach, sometimes it feels better when I reach. So it doesn't have a pattern and positions don't usually change it. Visceral pain tends to be cyclical, wave-like pain. They can have night pain or you can wake up from pain. And the big one that I like to tell people to pay attention to is if your pain changes with eating or bowel movements or urination. So if your pain gets better or worse with those things, it's starting to clue you in that it's not necessarily musculoskeletal, but there may be more of a viscerogenic component. And then, of course, our classic red flags that we all know so well when we should really be considering referring back to the physician. Okay, and I know most of you know these, so I'm not going to read it. So how might the viscera influence the musculoskeletal system? So how do the contents influence the container? There are a couple different theories, but one that I like to think of and that I feel often, and you can feel this on yourself if you want, if you back up and stand up, pretend you have an appendectomy scar. So kind of twist up your shirt and pin it down. And so that scar can create these direct mechanical tension lines of fascial tension that our body has protective patterns around. And if you try to reach, you can feel how your shirt limits your shoulder movement. And you try to extend your thoracic spine and you're limited. You have to free up this fascia for you to be able to reach. So this direct mechanical tension can influence our posturing and our container. And then there's another whole pathway through the nervous system. And so this is where it kind of gets fun and interesting. So I just gave you that one. The theory of how the viscera refer to the musculoskeletal system is because there's this poor recognition of where the pain's coming from. And there's a theory of, there is an embryological theory we're not going to dive into, but the two main that I like to point out is this multi-segmental innervation and the direct pressure and shared pathways, which will make more sense as we dive into this. So we all know our classic sign of a heart attack, right? We have chest pain and sternal pain, but you also can have left shoulder pain, left neck and jaw pain, and left arm pain. And did you ever stop to wonder, like, why? If you ask the person, is your arm hurt? They'll say it's excruciating pain. But is there anything actually wrong with their arm? They didn't bump it, they didn't hit it, they didn't injure it. It's the brain misperceiving where this pericardial inflammatory pain is coming from. And because of shared pathways and referral patterns, it refers down to the arm. And that happens a lot because the pericardial sac is innervated sensory partially by the phrenic nerve and vagus nerve. And if we remember the phrenic nerve, phrenic is C3, 4, and 5, keeps the diaphragm alive. So it's motor to the diaphragm, sensory to pericardium, sensory to some of the lung pleura and peritoneum, even to the fascia around the liver, sensory. So this crosstalk can start to happen because if you look at C5 is most of the motor to the shoulder, right? Our pecs, our delts, our rotator cuff muscles. So they're coming in through the same level of C5 and the brain misinterprets where the signals are coming from. And so you'll get pain in the area of the sternum and chest, but you can also have pain and sometimes just pain in the arm. And then if you look at the thoracic spine and the shared pathways with the sympathetic chain to the organs, you can start to look at how crosstalk at levels coming in from the organs to the thoracic spine can be miscommunicated as well to the musculoskeletal system. So if you look at this image, what's wrapping around the esophagus is the vagus nerve. And then it has communications through the plexuses and ganglions to the sympathetic chain. And the sympathetic chain runs up the anterior aspect of the vertebral bodies and the rib heads there. And it has direct communication with the intercostal nerves. So it has communication with the sensory to the skin. So you can start to see how dermatomes can share overlap with the viscera. And so if we keep that in mind, anything that touches the diaphragm can refer into the upper quadrants. So you start to look at what touches the diaphragm. You have the lungs, the heart, the liver, the stomach, the spleen, even the kidneys, and even the colon has anchors. So the hepatic and splenic flexure have direct ligaments that anchor up to the diaphragm. So you start to see how things happening in this container with all of our viscera could start to potentially crosstalk through the nervous system and create issues where the brain perceives it as musculoskeletal pain. And so we have our classic pain referral patterns. So we see the one of the heart, but another big one that I'll talk about, one of the examples, is the kidney and that classic low back pain and saddle pain, and how all of these systems crosstalk and can start to possibly be related. I left this, I'm not going to read it to you, but I left that in your handout for you just to have a reference, because your handout is really so you can take it back to the clinic or have this information to start to recognize things in your patient. Is this viscerogenic? Is this musculoskeletal? Is it hard to tell? Does the person have a history that starts to make sense, that you're like, oh, wow, you've had gallbladder attacks for years. Maybe that's what's contributing to your shoulder pain. So you have a new clinical reasoning tool for you to start to look at things a little differently. And how this possible internal contents could be adding to, and not just causing, but adding to pain and dysfunction in the musculoskeletal system. So what do I mean by that? I mean, if you have, say, right shoulder pain, and you have a history of many, many gallbladder attacks, every time you had a gallbladder attack, you started to posture and protect. Now, it could be referring to the shoulder, and the shoulder initially has some pain that's coming from the gallbladder. That over time, with this posturing and inhibition in the system, you start to get true mechanical breakdown. And now you can have true impingement syndrome, AC joint impingement, rotator cuff muscle fraying and tendinosis and issues, because they've been compensating and protecting and not using the arm in a proper alignment. So these things are very intermeshed and intertwined. And if we go into something familiar of where you're used to working and thinking about the container, what is inside of that? What is when somebody's always tight at T3, T4? You know, what is their SI joint always stuck? What else is there besides the musculoskeletal in the front of that that could be contributing? And we start to think about what's in front, the diaphragm, the intercostal nerves up above, or intercostal muscles influencing things through the rib cage and our mobility there, our psoas, our QL, our iliacus. All of those things sit right in front of the spine and the areas that we tend to mobilize and work. Start to think about what's in front of it. What's the body protecting? What might else be going on? And we start to think, what is there? The liver, the stomach, the spleen, the large intestines and small intestines, and look at the musculoskeletal system around it and start to think of it as a whole. And look at how high the lungs sit. The lungs sit up above the first rib. So this is a very common place where they look for pneumothorax that are missed. ENTs look here because often there'll be puncture wounds up above, and people don't think about the lungs sitting up that high. And then from a posterior view, people with low back pain, the kidneys, the large intestines, and how that might influence the protective tone in the QL and psoas and what's going on. And so you start to think of this system as containers stacked, right? We have the thoracic container, we have an abdominal container and a pelvic container, and how all these pressure systems need to influence each other as well. And so just to start to take you through a little anatomy layers, if you reflect back the abdominal fascia and you reflect back the abdominal muscles, we get to our first layer of the peritoneum, and then the greater omentum, and then the small intestines underneath that. And so start to think about, if you're getting to someone's psoas, what are you pushing through and what might else be going on? And so that peritoneum, that container, is a very thin sac, but it houses all the viscera, and you can see it needs to slide and glide, and all the organs within it need to slide and glide. And this is the greater omentum lift up with the transverse colon. So you can see how the transverse colon and omentum sit on top of the small intestines there. And all this tissue needs to be super slippery and slide and glide. And here you're seeing the jejunal ileum loops and the vascularity that has to go to it. And then, of course, there's a return of blood flow, which is cut and retracted there from the mesenteric veins that go into the portal vein and back into the liver. So all the blood flow from your intestines has to go back through the liver. So this balance of pressure systems and the mobility of the liver is really important for things like lower extremity lymphedema, swelling, ascites. All of those things start to be affected by if somebody has chronic constipation or chronic inflammation, SIBO now, right? Small intestinal bacterial overgrowth, food intolerances. If this area isn't moving well, it can become restricted. And then when we get to one of the case study or the research, really think about this area, the small intestines. If you have a C-section, they pull them all out and then put them back in. Or just simply pregnancy alone moves the small intestines up. So how is the I like to say, the furniture rearranged? How might this all be influenced? And that vascularity needs to be really mobile for all the nutrition, right? We eat, we need to be able to absorb nutrients and then get rid of waste. So it's so important that all these loops can slide and glide, and they're anchored back to what's called the root. So it's I like to think of the small intestines as fan coral, and it has a anchor to the bottom of the ocean, right? Or the root to the back wall. And all this needs to be able to slide and glide, but all the vascular has to be able to get through that. So you start to think about what's behind that. And so if you take the small intestine root out of the way, you can see it cut there where the vascularity is going through. What's behind that? Behind that are retroperitoneal fascia, are vascular to our lower extremities, right? So I was talking about lymph. So the venous return through there, and vascular to the lower extremities. So for performance, right, our athletes need to be able to have really good blood flow to run. If they have a lot of history of gut issues, is that even affecting their performance? So all of these layers start to intertwine. And of course, what's behind that is the sacrum and the lumbar spine. So you start to look at a different perspective of things. And behind the ascending and descending colon there on the sides, you have the QL and the psoas, right? So all these tissues are layered and connected. And I'm trying to help you start to think about, and hopefully patients are starting to pop into your head of, I wonder if these things have been some of the underlying issues that is keeping them from getting all the way better, keeping them from getting to higher level function. And so the transverse mesocolon anchors across that TL junction area. The small intestine anchors across L3, L4, L5. The sigmoid colon anchors across the SI joint, especially on the left. So you start to go, oh my gosh, could these intestinal restrictions that are from whatever be contributing to their mobility of their spine, of the mobility of how they function and move? And here's just, I put this in so you can really see how the large intestine can have folds. It's not just up, straight, and across. It can have a tremendous amount of redundancies, and how if there's restrictions here, that could be influencing back pain, or if somebody's had a colon resection, or. So in this, I put to really show you that diaphragm. Remember, I talked about being like a snowplow, has to move with every breath, and it massages the organs with every breath. So all of these tissues need to move well, and the diaphragm really affects that liver. And so you can see the liver there anchored to the diaphragm, and then the stomach's below it, and then the transverse colon hanging across with that greater omentum. So really looking at these tissues, organs aren't just floating around in there. Most of them have anchoring systems to the neighboring structures that help hold them in place. And that's the significance with this. And that's what I'll be talking about. If you look at the liver, this is the bare area, but the yellow lines are all anchoring. So the liver has direct anchoring to the diaphragm. And so in this first research that was done in 2020, this was done overseas, and it's all in my references if you want to read the direct research articles themselves. But they did a visceral technique to the liver on 14 subjects that had right shoulder adhesive capsulitis. So the liver and gallbladder tend to refer to the right. So if you go back and look at that image that I gave you, the referral patterns, you'll see that. And so these were 14 individuals that had right adhesive capsulitis of the shoulder. And they had 2 sessions of a placebo and then 2 sessions with visceral. And they compared pre and post to each one. And what they found was with the placebo, they didn't have as much change, but after the visceral manipulation, they saw significant improvement in pain, shoulder mobility, and a decrease in disability. So when you start to think about the liver, if you remember, I said the phrenic nerve is innervated by, the liver innervated by part of the phrenic nerve called Gleason's capsule. So the capsulation around the liver shares with that C5. Could that have that same protective pattern where the shoulder started to get tighter and tighter and tighter? And quite often they see in women that are perimenopausal and menopausal increase in especially right adhesive capsulitis. And they're starting to question, is that related to the hormonal changes? Because the liver has to filter hormones. And so you start to look at how might these things be related. So then if you look at the liver has the lesser omentum, the fascia that helps anchor it to the stomach. And so the liver and stomach themselves are connected. And if there are restrictions in the diaphragm or liver or stomach, could that start to influence digestion? Things like acid reflux, right? GERD, things like ulcers could be influencing how the stomach functions. And specifically, if you think about the liver and car accidents, I'm going to talk about this. So the liver itself is a very big, thick, dense organ. I think of it like a wet Nerf football. And so a person, say they're driving in a car and they get in a car accident, head-on collision. We focus on the car, right? If the car's crumpled, we look at the hood and the front fender and we're like, oh my gosh, I have to get that checked. But you wouldn't never not want them to look at the engine too, right? Or the electrical system or the hoses. You want them to check the inside and outside. But so often we get in a car accident as a human in our body and we're like, you know, the airbag might have gone off, the seatbelt yanked on them, but you're like, okay, I have a few airbag bruises and burns, but I'm fine. You need to think nothing of it because nothing really hurts. But that liver is super dense. And in a collision, in a split second, the G forces are amplified up to sometimes 100 times. So a liver typically weighs about 1.5 pounds. For that split second, it weighed up to 100 times more, so 150 pounds. And that shearing force could make it move faster and farther than the neighboring structures, like a hollow stomach. And so it can put torque and start to affect the diaphragm. And pretty soon that person maybe starts to compensate. Maybe they have neck pain, shoulder pain. Maybe they start breathing differently. Maybe that crosstalk through the system makes their shoulders start to become protective. And 6 months down the road, they have right shoulder pain and they don't attribute it to anything because they don't relate it back to the car accident because they didn't have pain at the time. So some of these things can become invisible diseases or processes that start to cascade. So this is sort of where I want you to start to think about that person's history. If they have a lot of trauma and collisions and injuries, maybe some of that underlying thing has been building up over time, contributing to their current insidious onset of whatever it is. So it's just this sort of start to think more globally, start to think with clinical reasoning with a bigger, broader spectrum so that you might be catching things that are otherwise being missed. Because this tissue needs to slide and glide. And here I put this image up. So what I want you to notice, I don't even know if you can see my cursor, but in the middle, it looks like a little squiggly bean. That's the esophagus, okay? And the esophagus runs through the diaphragm. And down below here, that C curve shape is a duodenum, okay? And from the esophagus to the duodenum is a ligament. It's called the ligament of Treitz. And this ligament is like 30% smooth muscle and 60 to 70% contractile. And what happens if you think about like a car accident and your head gets whipped, the esophagus can get pulled, right? And it can pull on this anchoring system. And because it has contractile tissue, it can spasm, but you can't go in and voluntarily tell it to relax. And it can hold a spasm. And so one of the first times I treated somebody after taking some of these visceral classes, I had to do a technique to this area. And they had had a whiplash and their neck range of motion was really limited. Like they could barely turn their head or look up. And I treated this area very gently, which I'll talk about in treatment concepts. And their neck range of motion, their shoulders relaxed and their neck range of motion significantly improved in all planes. And I thought, oh my gosh, they were being cinched from the inside. And I was trying to relax this, you know, the neck and the upper trap and the suboccipitals, and this wouldn't relax because it was busy protecting from this inside tension. So hopefully this is starting to get you to think about, oh my gosh, how is this all connected? And how might these inside pieces be influencing the outside? Let me take a sip of water. So this was research in 2019 on 60 subjects. They had 29 in the treatment group and 31 in the control group. And what they did was a treatment of visceral manipulation. The control group got a sham treatment, and the treatment group got an actual visceral manipulation treatment technique to this area, which if you want to read more, you can. And what they found was they had improvement in GERD symptoms compared to the sham treatment, but they had an increase in cervical mobility. And so again, it started to make me think about that patient of mine years ago where I had to work with their stomach relationship to the esophagus and this ligament of Treitz and how their neck motion changed. If they were a person that had restrictions from GERD and you freeze some of this up, would that improve their GERD symptoms as well as their neck range motion? So you start to see how these things again are intertwined. So here back to the lungs and looking at this area, that thoracic cavity and the pressure systems and how high the lungs sit and how they might be influencing posture and rib mobility and diaphragm mobility. And looking at the heart and lungs In front, you have the phrenic nerve coming down deeper behind the esophagus. You have the vagus nerve. And look at how high the lungs sit, and look at the scalenes up there, and the subclavian artery and vein, and of course the brachial plexus. And the lungs anchor. This was mind-blowing to me when I learned this. The lungs they're not just sitting in there, they have anchoring systems, and they anchor to the neck. So the pleural dome, the superior aspect of the pleural dome, anchors via 3 different ligaments. One of them is called the pleural vertebral that anchors to C7, T1, C7, C6. Then you have the transverse pleural ligament that anchors to the transverse processes of C7 and C6. And then you have the costopleural that anchors the lung to the first rib. So when you start to think of like why C5 is so vulnerable to so many shearing forces, when you think of the lungs anchoring to that C7, T1, and why this area is so much more rigid, and the influence of trauma to this area or infections, and how if the lungs have restrictions, and we're thinking about pneumonia, valley fever here in the Arizona where I live, you guys have, pneumonia, bronchitis, those winter colds, and then of course COVID, how all this might be influencing their neck, and start to think about their medical history. If they're coming to you with severe neck pain and their neck just won't let go, and you keep trying to stretch their traps and it won't let go, what are those traps protecting, and how might this be related to the lungs? And of course then the nervous system underneath, again showing the sympathetic chain and the vagus nerve and that communication as well. And what this blew my mind too, because when we go into our cadaver labs, right, we cut through the fascia, we cut around to see the pericardium and the heart within, but we don't think about these bungee cords that are anchoring. So our heart itself has bungee cords that anchor to the sternum and that anchor back to the thoracic. So T4, T3, T2, T1, and then several segments that go even up to C7, C6. And of course, the inferior aspect anchored to the diaphragm. So every breath, our heart is moving with it, right? This has to have mobility. And think about falls onto an outstretched arm, collisional forces, airbags, all these traumas affect this area. And so this area can be compressed and tight. You see those people that have really thoracic kyphosis. Is it just the spine, or is there an inside piece that from their trauma history, lungs, lung issues, heart issues, or the wind knocked out of them, these forces all can get kind of jostled. How might that be affecting their posture and their mobility? And so this was a visceral research done in 2021, visceral manipulation and forward head posture. So think about like that thoracic kyphosis, forward head posture, all of these things. What's the body protecting? In this, what they did was they took 5 subjects with chronic nonspecific neck pain, and they treated those structures, the pleural dome and those pericardial ligaments. And they did 1 single session with a placebo treatment, and then a second session with visceral manipulation. So they always sort of did a placebo first to see what happened, what changes, and then the visceral. And in this, after the visceral compared to the placebo, they saw improvement in posture, muscular activation, neck disability index, and visual analog scale for pain. So again, you start to look at, and they're finally doing research with specific visceral manipulation techniques that are from the Barral Institute to these areas and seeing changes. And hopefully more and more research will start to come. So now let's move down into the lumbar spine area, right? Like who in here hasn't treated the low back pain? And the physicians and people that go to the ER with low back pain, they know to do a thump test on the kidneys to see if there's kidney involvement for acute kidney stones and things like that. We know that can refer that the pelvic pain, the saddle pain, the low back pain area, all that can be involved. But let's start thinking about all of these structures and how they're layered. So of course we have our erector spinae, and then we have our QL. So many people have back pain, right? Their hand goes right to the QL. What is in front of the QL? You have the psoas there, you have the kidney, and you have the lumbar plexus. So you're seeing some of the nerves coming off of there, okay? And so you start to think about T12, L1, L2, which is sensory to sort of the pelvis area, right? Our iliohypogastric, ilioinguinal, genital femoral nerves. And then below that, L2, L3, L4, now you have the lumbar plexus, right? Those are all the nerves that go to the obturator nerve, femoral nerve, lateral femoral cutaneous nerve. What am I forgetting? I know there's one more, but all of these nerves are sitting between the psoas, QL, and the kidney. And that's important for what we'll be sort of talking about next. Think about how far and back the kidney sits. So bring your fingers to your back and feel the inferior border of your ribs, so that 11th, 12th rib space. Between that and your iliac crest is what's called Greinfeld's triangle. And so if you're not sure where you are, be at that level, but go to your spinous processes, go over the erector spinae and drop into that soft spot, that divot, that space. If you gently push into that, that's where your kidneys are. They're deep. And they sit in perirenal fat. Okay, so the kidneys are the one or the two organs that don't have ligaments that really anchor them into place. They're held in place by turgor. Turgor is like, you take a bunch of Nerf balls and you stuff them into a container, and you stuff enough in and you flip the container upside down and they stay in there, right? They don't fall down unless you hit the top really hard, and then they might fall. So kidneys are very vulnerable to trauma and collisional forces and falls, because they can kind of slide out of place a little, called ptosis, from these collisions, because they sit in perirenal fat. So they sit in fat. It's a little slippery because they have to move, right? Upwards of an inch to even 2 to 3 inches with really fast running and heavy breathing. They need to move. And so they can't have really strong anchoring systems. They need to be able to move well with breath, but all the neighboring organs help hold them in place. But they're vulnerable to ptosis. So and the other thing that they can happen is they can slide out of place a little, or this perirenal fat with UTIs and infections can become a little adhered, or even falls and traumas, the fat can become adhered. So they could slide out of place a little and then become adhered a little bit in a not optimal position. And so what does that mean? How does that influence the musculoskeletal system? Well, between the kidneys and the psoas are the lumbar plexus. And if that tissue can't move well, it can start to push on those nerves and create symptoms down the way, right? So you can get hip pain, low back pain, pelvic pain, groin pain, even knee pain, because the femoral nerve had branches to the saphenous nerve. Saphenous nerve goes on to become the peripatellar plexus. So you start to see how this area might influence things downstream. So in 2019, they did research on 20 people with low back pain, okay? And they had 5 visits over 5 weeks for 40 minutes. So one group had PT plus 10 minutes of visceral manipulation. The other group had PT plus sham. And so what they found was, again, comparing. So I made these short and sweet, so I didn't have to read you a ton of research. Again, if you want to go into a deeper dive, the research in depth is out there to read. But what they found was the group that had the visceral manipulation had an increase in lumbar mobility, they had an increase in function, and they had a decrease in pain in both groups. So both groups had less pain, but the function and the mobility was better with the group that had the visceral manipulation. Then I put this research in, even though it's older research. And the reason why I like this research is they looked at kidney mobility on ultrasound. So they did ultrasounds and they looked at how much the kidneys moved. They took 101 asymptomatic people, so they had no back pain, and they looked at how much their kidneys moved. And then they compared it to 140 people that had non-specific low back pain. And what they found was, in the group that had low back pain, the kidneys moved less. So how was that influencing those surrounding structures was what my brain starts to think about. And then what they did was they did some visceral manipulation compared to a sham treatment. And then they re-ultrasound and they showed an improvement in kidney mobility. And so that starts to give us that clue of we could possibly influence the mobility of the kidneys. And if the kidneys move better and the diaphragm moves and everything can move well, does that decrease pain and improve function? And so the case example, so this is not research, this was an example I used from one of my patients. She was a 74-year-old female that came to me. And she came to me, classic horrible low back pain, right? Bent over, was her left side. She said she's at a 9 out of 10. It took her a while even to get from her front chair to my office. She had a very antalgic, guarded gait. Transfers were painful. Standing tolerance was 5 minutes. Walking tolerance was 5 minutes. Getting her on the table, she couldn't lie supine. Like, she had to keep her knee all tucked up. So she was in significant pain. And she had back pain, hip pain, knee pain on that whole left side. Now, her history was she had a total knee replacement 3 years earlier. And what was interesting was during the time she was waiting for her total knee replacement, I asked her, have you ever fallen? And she said, yeah, while I was waiting for my total knee replacement, my knee was so painful, I fell countless times. So she had a history of falling many, many times. And so she had the knee replacement, and the knee felt better after the knee replacement, but she still had all this other pain. And this pain had recently gotten worse over the last 6 months to a year, to the point where she was now so bad that she couldn't function. And so I had to treat her, and I'll talk about how we discover where to treat. And I guess I can dive into a little bit of treatment concepts here. I'm assessing, I always pre and post test everything. I'm assessing range of motion and function and mobility and pain scales, all those classic PT things. So even though a large portion of what I do is visceral manipulation, I'm still using all my PT tools. And she had very limited hip range of motion, very limited trunk mobility. Neural tension tests were positive. She was symptomatic and painful. The assessment took me into the psoas QL area and her kidney area with feeling and seeing what wasn't moving well in her body. And so I had to treat the fascia, perirenal fascia around the kidney to the psoas and QL and free some of that up. And after a couple of visits of doing that, symptoms started to calm down. And I saw her for a total of 6 visits and had to treat both the fascia around the viscera and then the nerves themselves. So I had to treat her femoral nerve, lateral femoral cutaneous, obturator nerve, saphenous nerve, everything down the leg on subsequent visits as well. And so then we were able to get her back pain, hip pain, knee pain to, and then her 6th visit, she could, and her first visit, she couldn't sleep at night. She was waking up the whole night. Her 6th visit, she could sleep at night. She was able to walk 45 minutes to 60 minutes before her pain got to a 3. So she went from a 9 to, at worst now, a 3. At rest, she was at a 0. She could sleep through the night. She could lie flat. Her transfers weren't painful. Huge change in quality of life. And she had had some other PT just on her knee and back and wasn't making changes. So it was this internal piece of her psoas QL and the nerves being compressed and protective that wasn't allowing her to be able to even straighten that leg to start to get her whole system to calm down. So now diving into the pelvis and looking at the pelvic content. So here you're seeing the ovaries, the uterus, the bladder, the rectum behind it, and all these fascial layers. So there's endopelvic fascia that has fascial pouches and layers. The uterus has to be in a pouch so that during their cycle, it can engorge. The bladder has to be in a pouch so that during filling, it can get bigger and shrink down, right? Same thing with rectum. All these tissues are constantly changing in size based on our anatomy, physiology, and function. And so here you can see the fascial layers around and how they sit up against the psoas and the iliacus, and that relationship that it might influence the SI joint in the pelvis and lower extremity. And then the ligaments that help anchor them in place. And so Gail Wetzler is one of the Barral Institute teachers. She also teaches for Herman and Wallace, some of the classes, and the APTA and countless things. But she did some research overseas looking at sacral torsions. So it's not official research, but it was sort of like a case series that she did. And it was, I think, close to 20 women, and they all had sacral torsion. So whether it was a right on right or a left on left or, SI joint dysfunction, all of that was there. And what she found was in all of them, whatever rotation and tension they had tension in the uterus and the uterosacral ligament as well. And so if you look at that, you look at the uterus and the bladder and the sacrum and the rectum, they're all anchored back. So if that person, and they were all women that had had children as well. So during that pregnancy, how did they carry? What was their delivery like? That area goes through a tremendous amount of trauma in delivery. Both I would say pregnancy is like training for an athletic event followed by a trauma, but you're not really prepared for it, right? So our body is meant to do this, but it's traumatic. And so what she found was, if she could treat this relationship of the sacrum to the uterus in this endopelvic fashion and get it balanced, the women's rotations changed, improved, and their function improved, and their pain improved. So this relationship of the SI joint, and always just treating the SI joint, think what else is in front, and think about what their history is. Did they have 1 or 2 or 3 children? Have they had a C-section? Have they had an appendectomy? What else has gone on in that area? And so the next research kind of tag teaming off of this idea of this endopelvic fascia, what goes on, and thinking back to when I was talking about the jejunal ileum, the small intestine loops. When you're pregnant, it pushes everything up, right? The furniture gets rearranged. So the loops get pushed up and out. And if you have a vaginal delivery, they ideally all optimally kind of go back in place. If you have a C-section, they're pulled out, they're exposed to air a little bit, and then they're put back in. And they don't always quite get back in quite the right place. So this area really can be disrupted. And if you remember, I said the small intestine loops are anchored by that fan coral root, right? If that's pushed on and strained, and the loops are strained, it can create abnormal abdominal tension. And so if you think about those loops, like they need to slide and glide, like a bowl of spaghetti, and you put olive oil and you can stir it and it's all slippery. If you forget the olive oil, it can get clumped together a little. Well, very often in surgeries, laparoscopy, it's just air, right? They don't fully cut you open, but air gets in there and these areas can become adhered. And so it can start to create restrictions and cause problems. And again, showing you the root. The reason I'm showing you this is the next research was done on diastasis recti. So really common problem after pregnancy. And we always try to do all this abdominal strengthening to close the front, right? But if you think of the peritoneum and that root on the back, if it's tight on the back, it pulls back here, and you need to free up the back for this to close in the front. And so this was a 2021 case series, 3 patients that had diastasis recti. They received 3 sessions of visceral manipulation to the jejunal ileum over the course of 6 weeks. So they treated the loops, they treated the root, they treated the peritoneum, all this fascial layer. All 3 patients had an improved diastasis recti score and remained stable for 6 to 11 months after. So they were followed up on after. The pain in these patients decreased to a 0 out of 10, and they had increase in function as well as other domains. So this was presented at as a case series. I forget which year this was, as a poster presentation. This research article is well worth reading because it explains a lot of this. It explains exactly what was treated. There is treatment steps and techniques. There are videos. So the link to this research is, I think it's like a 30-page research article. So it's beautifully explained. And I use this clinically, and I've had patients clinically in 1 or 2 visits go from 3-finger diastasis to like 1. And it's amazing. And then you use the strengthening to help keep things closed. So if you're in pelvic health, or even if you're not, because you're going to get patients that, you know, later down the road even still have a little bit of a diastasis. If you have this tool set, could you help them get their abs kicking in better? Because that's everything about core stability and protecting the back. So this is beautiful research. If you want to read it, there's extensive more research done. This was done by Brandy Kirk, who is actually a Barral Institute teacher. She is in the Chicago area, and she's a phenomenal teacher. So I was really excited when this research came out, and I can tell you clinically, I treat a lot of women pre and post pregnancy, and this is a game changer to know these skill sets. And these are all taught in the first level visceral class if you're interested in that. And I'm not trying to promote just the Barral Institute visceral work. Any kind of visceral work, if you can start to get better educated and have these tools to help your clients, you have a broader reach and you're helping that person in a more global way. In the visceral work that I do, and what I'll talk about with the Barral Institute in a moment, and the treatment concepts that I use clinically, this research was done in 2020 on muscular torticollis. And the reason I put this in here was, right, working with babies, the only way to tell if something's not comfortable, right, is a baby will cry and flinch and complain. And the current treatment for torticollis is a lot of direct stretching, and they can be quite fussy and crying. And so the idea was, could we use some of these techniques that are done, visceral manipulation and neural manipulation, on these infants every 2 weeks for 8 visits. They received 30 to 50-minute sessions. So they were 4-month-old, 10 4-month-old subjects. And what they did was with this treatment technique is to make sure there was no fussing or pain. So they did all these techniques to help treat torticollis, but without causing a pain response. And what they showed was after they had an improvement in cervical range of motion, active and passive range of motion, and the infant motor scale, even 4 months after, and they were able to achieve the results without pain. So all of the visceral work that I'm going to be talking about in the work that I use in the case examples and some of this treatment is done without eliciting a pain response. And so that idea of no pain, no gain really is not appropriate here. So when I'm working clinically, the way this work is developed is to feel into the body, to feel where the body has restrictions. So if you remember, I showed you that line of tension, right? We have lots of tools. We have range of motion tools. We have functional movement scales, right? The Gary Gray approach, all these different approaches to look at how people move. So if you don't have the skill set, you can still start to see where is there something in the viscera that might be contributing, where they might not moving well. In the Barral work, you're taught something called general listening. It's feeling lines of tension into the body, feeling where those fascial lines are. General listening is like, where's the big one? Where's the biggest one that the body's protecting, right? If you got hit in the gut, you would kind of protect. So it's feeling where that line of tension is to find the primary area. Local listening, I like to think of like feeling like a steak. Is it medium? Is it rare? Is it well done? You're feeling density. So what's the density of the tissue? Where is your hand being attracted to an area that's maybe restricted, dehydrated, more dense, changed? And then you use like an end feel, a mobility assessment to see how well that tissue is moving. Does it feel like something's tangled or stuck or restricted? And then the treatment itself is very specific. So it's a very gentle, specific technique to finding that precise area that needs help and treating that precise area. And so much like a bunch of necklaces tangled, you don't just go in and pull them out, right? Or a knot in a rope. Pulling harder doesn't work. You have to push the ends together. So a lot of this is done with what they call like an induction, or kind of waking up the mechanoreceptors to get the tissues to move and to slide and glide. So you're getting those mechanoreceptors to start to shift and shear and slide and glide. Just like you push the ends of a necklace together, they start to come apart. And then you carefully detangle so that you're not causing any collateral damage. So this is not tearing apart adhesions. This is not aggressive work. It's very gentle and freeing it up. And it allows the nervous system to respond. It allows the proprioception, the mechanoreceptors, all those things to respond with this mechanical dialogue to the brain to allow things to start to move different. Then you retest your mobility and you refeel your density to see things change. And me, clinically, I pre and post test range of motion, function, posture, pain. What changed? Neural tension, what changed? Okay. And then they come back on follow-up visits and tell you, like, I noticed this and that. But usually if you start to detangle where that primary area is and the body doesn't have to protect as much, the autonomic nervous system settles down, their posture changes, and life becomes movement and their home program, right? Breathing, moving, squatting, lifting, everything, they start to move different. It keeps correcting. So we're not curing, we're not healing. We're freeing something up and letting the body self-correct. Okay, so it's this holistic approach. I use a tremendous amount of PNF to neural read the system so that the brain and neural plasticity doesn't keep protecting. It will think it needs to protect if you don't get them to move differently. So home programs are super important. I love Pilates-based things and yoga-based and breath work and mindfulness. And now we're seeing a lot of vagus nerve work and things like that to help awareness, right? Body scans for pain, changing all of these things. So you're still using all of your other tools. And then, of course, getting them stronger because they've been protecting, because there were mechanical restrictions. You may still have to do joint modes and all these other things. So all of these layers interweave together. And typically, because this is such deep work to where the body's been protecting, we say when you're using visceral manipulation, generally you want to do it every 3 to 4 weeks. You want to treat, it doesn't mean they're not coming for other things, but the big things you're treating and letting the system integrate. It's very gentle, hands-on, pain-free, right? We're not trying to get a fuss signal or make anybody cry. And then typically I treat patients 30 to 60 minutes. Evaluations are longer, but if you're using the visceral approach, and it might be 30 minutes of visceral, integrated with PNF, integrated with educating on home program and posture changes and all of these other things. Because again, now that they start to move different, the continuing correction in their body continues for days to weeks. And so it's sort of this holistic approach. In summary, visceral curriculation is really emphasized on anatomy. Knowing if you're mobility testing, you need to know, are you on the bladder or on the uterus? Are you on the liver or are you on the stomach? So anatomy specific is really important, and understanding how this anatomy affects the whole body. So Jean-Pierre Barral says the body hugs a lesion. So sort of think of that like you got punched, and what is the body protecting? What else is going on there? Visceral manipulation is a gentle, precise treatment via mechanical dialogue with the tissues to assist healing. So you're using minimal force with maximal specificity. Can you find the exact spot the body wants help? And then you can feel more than you think you can. Trust your hands. So the next time you go in and do a psoas release, think about the layers you're going through. Think about if you feel any restrictions in there. If you do, could you gently nudge, not aggressively, and let things soften before you get to that psoas? Could you add breath work? Could you add hip range of motion? Could you add other mobility things to help the body detangle in a more gentle way so that it doesn't have to keep protecting?